gentlemen, my name is Salma Kamal, and today I will be discussing one of the most important and emergent topics in medicine, personalized medicine and pediatric pulmonology. First, I want to start off by asking a question: what is personalized medicine? Personalized medicine is the tailoring of medical treatments to the individual characteristics of each patient, therefore obtaining optimal results in treatment. Like, how can we achieve such a thing? It's a really, it sounds like a great approach, but how can we achieve this in real life? Well, this approach relies on scientific breakthroughs in our understandings of how a person's unique molecular and genetic profile works. This helps us predict susceptibility to certain diseases, as well as asserting responsiveness in performing treatment, and of course, safety of treatment. Okay, so why is personalized medicine important? What can it offer? Well, personalized medicine has the potential to tailor therapy with the best treatment and the highest safety margin to ensure better patient care. It also enables patients to receive better diagnoses, earlier diagnoses, risk assessments, and optimal treatments, all while reducing the financial burden on the healthcare systems. Now, I know I started the introduction by saying I'm calling it personalized medicine, but is it essentially the most optimal name to call it? Well, this is still a point of debate. According to the National Research Council, personalized medicine is an older term with a meaning that sort of conveys a misunderstanding. Therefore, they chose a more preferable term, which is precision medicine. However, this concern that the word personalized maybe is generally misinterpreted, that the treatments and preventions are being developed uniquely for each individual, which is not the case. The case is that precision medicine, it focuses on identifying which approaches will be effective for which patients, based on genetic, environmental, and lifestyle factors. The Council therefore prefers the term precision medicine over personalized medicine to convey better accuracy. However, some people still use both terms interchangeably. Now for the first case, discussing how personalized medicine can be put to action with bronchial asthma with my colleague Salma Tariq.
Hello, good evening everyone. Now let's start with the first example of personalized medicine, which is bronchial asthma case. For example, if an asthmatic 8-year-old patient comes to your clinic who is strictly adherent to his medication, which is inhaled corticosteroids, and his mother noticed no improvement upon using this drug, and she also pointed out that her cousin years ago had the same condition and he was improved by using inhaled corticosteroids. So there is a certain investigation that should be done for this patient to assess his condition. Either measuring the eosinophil level in respiratory secretion, or echocardiography to rule out any cardiac asthma, or 24 esophageal manometry to assess GERD, or lastly, sweat chloride level. Well, the right answer is measuring the eosinophil level in his respiratory secretions in order to differentiate between two endotypes of bronchial asthma, eosinophilic asthma and non-eosinophilic asthma. Eosinophilic asthma is characterized by high blood levels of eosinophils, and in non-eosinophilic asthma there is an absence of elevated eosinophil number. Also, bronchial asthma can be differentiated by according to phenotype based on inflammatory cells, eosinophils, neutrophils, and paucigranulocytes into two subtypes, Th2 high and Th2 low. Th2 high is characterized by high levels of eosinophils, which consists of two types, early onset and late onset. The early onset it has allergic sensitization and is responsive to inhaled corticosteroids, while the late onset has no allergic sensitization and is ill-responsive to inhaled corticosteroids. While the T2 low is neutrophilic and paucigranulocytic. So by this we can say that the child has Th2 high subtype of bronchial asthma, and he should and a different medication should be prescribed for him rather than inhaled corticosteroids after measuring the cell count of eosinophils in his blood. And now with a case of GERD with my colleague Nada Shahri.
Another example on the importance of precision medicine is this case. A patient with chronic depression is already on citalopram, and GERD has no response to conservative measures and alginate therapy. So according to the guidelines, you start a PPI, omeprazole. After a few days, the patient is admitted with syncope, ECG revealed ventricular tachycardia with QT prolongation. What could have been done to avoid such complication? Prescribe pantoprazole instead. The observed complication is normal with citalopram. Observed complication is due to electrolyte imbalance related to her depression state, or counsel her of regular assessment of citalopram drug level. Well, these complications are known as the serotonin syndrome, which usually occurs when the citalopram cannot be metabolized, which elevates its levels in blood. So pantoprazole should be prescribed instead. Why was it more convenient for this patient than omeprazole? As we all know that GERD patients are routinely prescribed one of the 6 FDA-approved PPIs, which are usually inhibit the enzyme CYP to C19 in varying degrees. And using the phenotype pantoprazole 13C breast test, we can identify the poor metabolizers and the extent of phenoconversion of the enzyme activity by the PPIs. So a study was made on newly diagnosed patients. After 30 days of treatment, selected randomly from the 4 PPIs, omeprazole, esomeprazole, pantoprazole, and rabeprazole, we found that omeprazole, esomeprazole are strong CYP2C19 enzyme inhibitors, while the pantoprazole, rabeprazole are weak CYP2C19 enzyme inhibitors. That's why concomitant use of omeprazole with other medications metabolized by the same enzyme which the omeprazole inhibits will precipitate these clinical complications. Other indications include the clopidogrel, thalidomide, and diazepam. That's why precision medicine was so important to save these patients from these complications. Thank you.
My name is Rita. This is a case, a patient with cystic fibrosis inducing terminal respiratory failure has finally received a lung transplantation after 2 years on a donor list. Few weeks later, he developed worsening respiratory distress and requires reventilation. The doctors explained to you that he developed PO, which is bronchiolitis obliterans. You ask them what should have done to avoid it or protect it. Number one, nothing could have been done. It's a fatal unexpected complication. Two, some markers such as B lymphocyte kinase could have protected it before it happens and spare the lung to a more expectorant donor. Three, blood grouping was enough. The answer is two. Some markers such as B lymphocyte kinase could have predicted the event before it happens. Lung transplantation should be performed before excluding any possibility of rejection of the transplantation. To exclude PO, which is bronchiolitis obliterans, we can perform non-invasive whole blood profiling, searching for some biomarkers, including POU class 2 associating factor 1, or T cell leukemia, protein 1A, or B cell lymphocyte kinase. If one of them are elevated, the patient has more possibility to develop PO after transplantation. In this case, we prefer not to perform the transplantation and spare the lung to another patient. Thank you.
Okay, good morning. My name is Nora. Our case here is about cystic fibrosis. So let's read the case together. 2 patients, A and B, with cystic fibrosis are following up with the pulmonology specialist. They are cousins. The doctor has ordered some tests, after which he decided to prescribe to patient A Orkambi drug. The mother of B comes to meet the doctor complaining that this is unfair and that her son might benefit from this new drug. So what should be the reasons by which the doctor will explain his decision? A, Orkambi reduces the airway inflammation and her son currently doesn't suffer from any significant manifestations. B, the drug is still under trial and the mother of A accepted to undergo the trial while he expected that mother of B would refuse it. C here can be the new antimicrobial drug, and the tests done don't reveal the same antimicrobial susceptibility in both patients. D, or can be stimulates the CFTR function, and this won't improve patients' B condition. The answer is going to be D. So let's talk more about cystic fibrosis and its new methods of treatment to understand why I chose D. First of all, as we all know, cystic fibrosis is one of the life-shortening diseases known due to mutation of the CFTR gene, and up to date there are more than 2,000 type of mutations that have been discovered. These 2,000 type of mutations are reclassified into 6 major classes. Class 1, 2, 3, 4, and 5, and 6. And after pathing through more details of the 6 major classes, we have found that there are some mutations that affect the function, while others affect the quantity. And from here, the idea of the CFTR modulators, which are the new drugs that are used for treatment of cystic fibrotic patients, was developed. What are the CFTR modulators? They are defined as small molecular compounds that are capable of increasing cell function. So we can understand they will mainly work on classes that affect the function, as in class number 3 and class number 4. One of them are the activators. The activators work by increasing the cyclic AMP inside of these channels, making them more active. The potentiators, they work by increasing the opening capability of these channels, thus they compensate for the defective conductance of the chlorides. They are known by ivacaftor. These two are mainly used with class 3 and class 4. Actually, did not only stop here, they developed a new drug that actually didn't only work on the function, it succeeded in treating one of the most common mutations that all of you are going to meet in your clinics or in the hospitals, which is class number 2 mutation. So let's know more about class number 2 mutation to understand how these correctors work. In class number 2 mutation, the problem here is in the trafficking. The cell goes premature degradation of the misfolded protein, preventing its expression on the surface. Thus, the correctors here came and they act as protein shapers. They protect these misfolded proteins, preventing the premature degradation, allowing their expression on the surface. Thus, they succeeded in increasing the amount of the CFTR at the cell surface. These drugs are known by lumacaftor. So back again, the activators and potentiators, they work on mainly class 3 and 4. The correctors can also work on class number 2, which is the most common type of mutations that all of you are going to meet. These drugs actually work in different combinations. One of them are the Orkambi drug. It's a combination of both potentiators and correctors, and this drug that I have mentioned before in my case. So I hope now I had answered the question why we did use with patient A the Orkambi drug, while patient B we didn't use it. It's definitely because he have different type of mutations, and this explains that although we do have two same patients, nearly the same age, cousins, diagnosed with the same disease and same manifestations, where we treated them differently, and this quite explains what is precision medicine or personalized medicine. Our next case is about respiratory syncytial virus.
Good evening, everyone. Today I'm going to discuss a quite interesting aspect about respiratory syncytial virus and how variation in the human genome can affect the degree of severity of the virus in each individual. First, let me begin to give a quick recap about the virus itself. Let's start with the prevalence and the magnitude of the virus. It's well known to be the most common factor of severe lower respiratory tract disease among infants and children during their first 2 years of life. The majority of the cases resolve with insignificant clinical picture of common cold. However, some of them develop to severe bronchiolitis and pneumonia. Premature infants with impaired immunity are a very high-risk group, and according to some statistics, according to United States Health Institute statistics, there was 4,500 deaths out of 90,000 hospitalized cases annually, and on a wider scope, there were 66,000 deaths out of 3 million hospitalizations worldwide. And now, let us move on to the pathophysiology and the clinical picture of the virus. The respiratory syncytial virus invades the bronchial epithelial cells, causing severe inflammation and edema, which will cause the inflamed membranes of these cells to fuse together, forming a syncytium. This syncytium will follow up with further accumulation of dead epithelial cells, edema, and this will cause an airway trapping in the alveoli, which will lead to the classical clinical picture of poor gas exchange and increase in the work of lung breathing, and also the classical expiratory wheezes. And now, the effect of host genetics on the innate defense. It's known that the hydrophilic surfactant proteins A1, A2, and D are an integral part in the pulmonary defense mechanism, and genotypic study has proved that any gene polymorphism will cause, according to these proteins, will cause a further degree of severity in the respiratory syncytial virus on the host. Moreover, the toll-like receptor 4 and RSV-F protein will also cause, if any gene polymorphism occurred in it, will also cause a higher degree of severity of the virus. And now, there has been an interesting study conducted in Denmark in the year 2008, which compared how the genes of the identical twins and non-identical twins affected the degree of severity of the virus. In this study, there were significantly higher concordance or similarity rates in the susceptibility to severe RSV infection in the identical twins, with a concordance rate of 0.66 in comparison with the non-identical ones, which was 0.53. This supported the role of genetic factors in contributing to developing severe RSV disease. In conclusion, the new genomic approaches may untangle new biological aspects that can guide promising vaccine strategies, and the hypothesis supporting the link between individualized host genetic determinants and RSV will trigger a new approach to emerge, which is known as personalized vaccinology. And now I'm going to leave you with Lina Shokran that will discuss the take-home messages.
For the case of severe asthma, mepolizumab and reslizumab are administered for eosinophilic asthma, specifically the T2 high pathway, since the T2 low pathway treatment is only predictable since it has an unclear pathophysiology. And for the patients who suffer from GERD, you should decrease the dose of omeprazole and esomeprazole, since they are strong CYP2 C19 inhibitors. And or you could administer pantoprazole and rabiprazole instead, since they are weak inhibitors, and this is to avoid any drug interaction. And for the case of lung transplant, by using non-invasive blood profiling for these three markers, you can predict the occurrence of bronchiolitis obliterans and avoid the worsening of the respiratory system after any lung transplant, and the lung could be spared for more promising patients. And as for the cystic fibrosis, people who have defective genes for the CFTR proteins and lack chloride channels, the Orkambi is not prescribed to them. And to improve the CFTR function, you could use the CFTR modulators, which are potentiators and correctors. And as for the respiratory syncytial virus, the genetic polymorphism in hydrophilic surfactant proteins and RSV-F protein leads to more serious infections and weaker immunity. And now there's a new approach of personalized vaccine being considered. احنا كطلبة بيقولوا لنا انه اهم حاجة انه the patient is our priority and we have to study hard in order to refine the right treatment. But as Hippocrates said, it is far more important to know what person the disease has than what disease the person has.
Thank you all for your time. I just want to say that this presentation is dedicated for the soul of Dr. Hala Hamza, and special thanks again to Dr. Mona Falaki and our previous chairman, Dr. Iman Ihsan. And I also want to, all of us want to offer this for Dr. Hala Hamdi. And I also want to thank Dr. Suhaila Lutfi.
سهيلة تعالي عشان احنا عرفنا سهيلة خالص، كل شويه اقول لها معلش لازم تزودي لي اسم على البرزنتيشن ده، لازم نعيد طبع البروجرام، فهي اتقرفت معايا قوي. وطبعا محمد سمير انا بشكره بشكل عام لان هو برده كان ممكن تيجي وطبعا يعني عايز اشكر جدا يعني في الاخر بيتر افضل لان هو بيساعدني في حاجات كتيره قوي. ازيك يا بيتر؟ وعايز اقول ان دكتور ايمان حسين استنت سنه السنه اللي فاتت. اي هوب كلنا نكمل عليها. احنا نجيف تشانسز للناس الصغيره. بليز يا دكتور تعالي عشان حضرتك اشكر حضرتك. وطبعا عايز اشكر دكتور اسامه حسين لانه برضو في الكونفرنس اللي فاتت بتاعته هي الاود اس ان احنا نشارك في البرزنتيشن وبس.
شكرا يا جماعه ليكم، فعلا مجهود جميل، وانتوا مش عايزه اقول ادفانس لدرجه ان احنا اللي قاعدين وسامعين محاضرات عن السيستيك فايبروزس وحاجات حاجات جديده قوي يعني. برافو عليكم، حلو قوي، برزنتيشن جميل، شكرا قوي.
يعني طبعا انا كل سنه وكل مؤتمر ببقى قاعده مستنيه البرزنتيشنز بتاعتكم. يعني احنا فعلا بتدينا فيري جود يعني امل كبير قوي في المستقبل، وان انتوا دول احنا دول فيوتشر زملائنا في الفيوتشر ان شاء الله في الاطفال وفي الجراحه في كله. ثانك يو فيري ماتش بجد على كل البوزيتيف انرجي اللي بتديها لنا، وشكرا دكتور انطوان وشكرا دكتور سيد كل اللي بيساعد معانا. شكرا ليك جدا ويا رب دايما كده في كل
اشكر اساتذتي اللي قعدوا مستنيين عشان خاطر يحضروا. دكتور مرتضى طبعا واحد من الناس اللي اول حد عمل موضوع الساينتفك داي بتاع الامتياز، وده اول حاجه ادت الناس فكره ازاي الناس الصغيرين في السن غرفه المقام طبعا يقدروا يعملوا حاجات كتيره كويسه جدا. وطبعا دكتور سونيا قعدت لغايه دلوقتي، ودكتور ناديه، وكل الشير بيرسونز، دكتور يعني دكتورز الجمال اللي قاعدين معانا. يعني انا بشكرهم كلهم، يعني بشكر كل الناس اللي قعدت مستنيانا لغايه دلوقتي. تعبناكم وقعدناكم، بس اي هوب ان ات واز ورث يعني القعده. شكرا.
شكرا جزيلا. بعد الصورة صورة البرزنتيشن ده انا عايز اقول لكم، يعني انا بقول الله عليكم، الله حاجه منتهى الفخر والسعاده. خليتونا واحنا قاعدين احنا اون ساتسفاكشن، يعني في سعاده داخليه لا تتخيلوها. لو انا هقيم برزنتيشن زي دون مفيش احلى من كده، مفيش اجمل من كده. عندكم كل الكوميونيكيشن سكيلز بصوره هايله جدا. ايكون حاجه ما حصلتش. الكوميونيكيشن سكيلز
عايز اشكرهم.
عندكم ثبات انفعالي هايل. عندكم تدريب سن حاجه ممتازه. انا اسمح لي دكتور انطوان حضراتكم والتيم، دي تجربه رائده انا بدعوهم جميعا نكرر التجربه دي في جامعه اسوان وفي مؤتمرنا القادم في مارس. بدعوكم كلكم تشرفونا في كونجكشن مع الطلبه الجمال اللي عندنا في اسوان. يا ريت تنورونا.
ثانيه واحده بس قبل ما الناس تمشي، انا اي وانت بس كنا اسم الاطفال وانا يعني عاملين ميدلز للبنات اللي قدموا. نورهان ندى ممكن تيجوا عن نورهان حاتم، دكتور منى حضرتك تديهم دول. يعني لو يعني مش لازم تعمليها، ممكن تديها له. حبيبه اسماعيل، دي ندى مش لازم، ممكن ننكرت حبيبه. نوران جمال، و ميرات اشرف، ورنا سعيد. وسلمى طارق، و ريتا بطرس، و سلمى كمال، وندى شهري، ونورة خالد طبعا، ولينا شكران. نورا. ريتا. ولينا شكران وآية ياسر. خلاص كده. ايه انت مخدتي المادة بتاعها؟ وآية ياسر. شكرا جدا.